Okay, perfect. I think we should be all good. We're a couple minutes after here, so hopefully everybody's had time to join. Welcome everyone to our webinar. Today we're going to be discussing GLP-1 myth, facts, and what actually matters. So, just kind of a conversation between myself and Dr. Bodepudi, talking about, some of the things we most commonly talk about with our patients every day. So we're super glad you're here. My name is Corey Gosnell. I am a PA here at knownwell. Before I came to work here in obesity medicine, I had done a lot of research in diabetes and metabolic disease in general. And so when I had the opportunity to come to knownwell, I was super excited. We have a wonderful team here, so very grateful to be here.
Hi, good evening. My name is Sreevidya Bodepudi. I'm a primary care and obesity medicine doctor by training. During my training, my family medicine years, I was seeing a lot of patients struggle with weight and a lot of weight-related comorbidities. That can include things that we commonly think about, things like diabetes, heart disease, but there's a lot more that goes behind weight. We think about emotional stressors, physical stressors, patients struggling with movement, patients seeing how this affects mental health. And it really encouraged me to think about a fellowship training. So I spent a 1 year time doing a fellowship training in Boston. And so part of that training, I got to take care of adults and pediatric patients. And so that's really what got me to go to knownwell. I really wanted to take care of patients, do primary care, do obesity medicine, see pediatrics, really kind of do everything. And so no one really felt like a good place to come to. As Corey said, I think the environment here is very collaborative, and it's so fun to see our patients do so well and talk about their journeys and their struggles of getting to this point. And we always are here to champion our patients moving forward.
Absolutely. So, moving forward, we're going to talk a little bit about GLP-1 myths. There are plenty that are scattered throughout the media that we all see, both on social media networks, news outlets, things of that nature. So, these are some of the things we're going to talk about throughout the presentation today.
But first, I think it's important to take a minute and kind of set the frame here. What are GLP-1s? So GLP-1s are glucagon-like peptide 1 hormones. These are hormones that our body naturally produces. Each of our bodies do produce this hormone. It's produced in the gut, and it does help with hunger regulation. In humans, this is one of the hormones that plays into hunger. It's not the only hormone. And in us, it lasts just a few seconds. The naturally produced hormone is very short acting. And so some really smart researchers found out that this is a very helpful tool that we can augment to help regulate hunger. So these GLP-1 receptor agonist drugs, so commonly known as like Ozempic, Zepbound, Wegovy here, these medications help target those GLP-1 receptors. They are longer acting. So they target similar areas of the gut to help regulate hunger and satiation. So they last longer than the traditional hormone that we make in our own body. So the goal is, can we get more of that hunger, longer acting support here? And so now we're going to get back into kind of our topic here today for myths versus facts. Our first topic today, we're going to talk about the myth here is GLPs damage your stomach. And so we want to talk a little bit about facts here, how they slow digestion by design. Corey, I'd love to hear a little bit about what your thoughts are about this topic.
Absolutely. So this is definitely one of the things we talk about with patients the most. A common misconception with GLP-1s and a concern that patients have when considering starting a GLP-1 is that there's going to be some sort of damage to the stomach, issues with the stomach lining, things of that nature. And so we talk a lot about the mechanism of action of GLP-1s. And one of the primary areas that GLP-1s target is to slow gut motility, which is essentially the movement of food through your gut. So GLP-1s work to slow digestion, and this is one of the mechanisms by which people tend to feel, fuller faster on GLP-1s, and they tend to not be able to eat as large a portion sizes, and that is by design. So with that can come along certain side effects, but usually these are self-limiting, and as a patient continues to acclimate to the drug, they tend to lessen in severity over time. So most commonly, some form of GI upset, whether that be nausea, constipation, diarrhea, some acid reflux, and some of these things can be triggered by different things that you might eat, fatty foods, spicy foods, different things of that nature. So that's something that we, combat as someone starts a GLP-1 if and when it does present. More concerning side effects that we think about, nausea or vomiting that just doesn't stop. You're not able to eat anything, signs of dehydration, severe abdominal pain, constipation, or diarrhea lasting several days. All of these things would warrant, of course, further medical evaluation. And I would say that, those things tend to be very much so in the minority of responses that we see on GLP-1s. Typically, more of those common side effects that we're dealing with. And we're seeing that patients tend to be tolerating, the newer generation GLP-1s quite well. And there, is a good amount of therapeutic benefit there. Sri, any additional thoughts there?
Yeah, I think to add on to that, I think a lot of patients, I think one misconception that comes up within this misconception is patients worry about like the long-term damage, or I think a common phrase I hear is that your gut is slowed down forever, or these medications cause gastroparesis, which is a medical term for slowing down of the digestive system. But for a lot of these patients, like if there are seeing that these medications slow down motility to that severity, these are reversible causes. We know what the agent is. There are plenty of other medical reasons for why gastroparesis can happen. But when we think about GLPs and slowing down, like Corey mentioned, these are kind of the intended goals of this medication, but they're reversible. So if a patient really isn't tolerating these medications well, this might not be the right agent to think about. But we expect patients to make a full recovery once they stop that agent here. So.
Absolutely. And of course, how we manage these here at knownwell, we're very proactive up front. I think patient education is something that we really specialize in here. All of our clinicians provide an individualized approach to each patient depending on their past medical history, what specific agent we're using for that patient, just to kind of prepare them. These are the possibilities of what you might experience. These are warning signs of things that would warrant further, evaluation. And so with that, we titrate dose depending on the patient's response. This is definitely not a one size fits all situation. It's very personalized to each patient. We talk about eating more frequent, smaller portions of food. Any of my patients that are listening are like, yeah, that's Corey says that to me every visit. But it's so imperative just because we know that GLP-1s, they limit those portion sizes that you can take in. And so having the more frequent, smaller portions of food is much less likely to cause one of those more common side effects that we sometimes see. I mentioned the spicy foods, greasy foods, things like that, which can be triggering on a GLP-1. And then, of course, we really push the water. So that's going to help keep things moving through the gut. It's going to protect your kidneys, a whole host of benefits there. So we really try to approach this proactively, like I said, and just provide that individualized approach. In addition to that, we have a very multidisciplinary team here at knownwell, so including our nutritional counseling through our registered dietitians who are phenomenal, health coaching, and some of those other things to really create a holistic approach is really important.
I'd love to hear a little bit about your experience too, Corey. I find that I very rarely have a patient who stops GLPs due to side effects. I feel like there's plenty of other reasons that this happens, but I find that I can work with patients with ourselves as clinicians, our dietitian team. But I find that as patients go through this journey, we can kind of figure out what those culprits are for a lot of patients. I feel like it's a handful of patients every year that I find that this drug class just doesn't work from, which is totally okay, of course. But I find with the right guidance that patients do a lot better. So I would love to hear about your experience too, clinically.
Absolutely. I would echo that for sure. I feel like most of our patients, and there are different things that can be triggering, right? Certain food groups or certain things might incite various side effects for one patient and not another. So that's where that individualized approach comes in. But typically, if someone does have a pronounced response, whether that be after we've just titrated up to a specific dose, we can typically work with them, whether that means going back down to the dose that, we were on before, just to give their body more time to acclimate, working on some of the things that are triggering that response and trying to kind of modify things from a dietary standpoint or whatever the case may be. I've definitely had a similar experience with my patient population, and the vast majority of the time we're able to make that work, and it's much more rare that someone ends up having to come off of that GLP-1.
Yeah, and I find that we get a little longer time with our patients for those new visits, and that's usually a good time to kind of go through a patient's history, kind of pinpoint areas that might be more of a challenge. So if a patient's telling me at baseline they already struggle with heartburn, we might talk about a plan of action, or if a patient has had some sort of surgical history or medical history that I think might be concerning, I think it's really helpful to do like holistic evaluation here so you can really prepare the patient, kind of talk about side effects. And those are patients we might think like this patient might be higher risk in my mind. Maybe I'll see them sooner because I'm worried about what might happen, right? So kind of recognizing that we have some flexibility within our interactions with patients to kind of really personalize that care, and hopefully find a way to make this work if that's kind of the patient's goal.
Absolutely. I love that. Let's move forward to our next myth here. So, myth is everyone loses the same amount of weight. So, we have patients come to us all the time and they say, well, my sister, my cousin, my best friend was on Wegovy and lost X amount of weight, and so that's something that we talk about quite a lot. Everyone's journey on a GLP-1 is completely different. So, we're going to get into some myth busting here with that one.
Yeah, absolutely. So it's really interesting when we look at clinical trial data for some of these newer medications, when we think about some of these newer GLPs, average weight loss, depending on the drug specifically, I'll quote injections right now, are kind of between the 15 to 20% of weight loss over a year to year and a half. It's incredible how many patients come in and tell me, oh, my friend, partner, mom, so and so lost 50 pounds in a month and a half or 2 months or something. And that's another concern, which we can, happily talk about as well. But it's interesting to see how patients respond to these medications. These are molecules that, of course, our body does produce some of this naturally, but these are newer molecules to our body. So everyone will react a little bit differently. Some people won't react right away. Some people, the dosing will be more of an issue. So we need to find that dose that works for a patient. Some people are what I call hyper responsive. So going back to that patient who might lose a significant amount of weight in that first month or so. So I think that's kind of where there's a lot of variability. But there's so much variability depending on other aspects of a patient's health. There have been trial data to show that patients who have type 2 diabetes tend to see less weight reduction, compared to patients who don't have type 2 diabetes. So that could be a part of in playing the role here as well. We know genetically there can be variability. So I have sometimes patients who tell me my mom was on this drug and also didn't do as well. And that's always interesting to hear. I think time in life, like menopause, can be another driver. Um, sex can be another driver. We see more weight loss, sometimes based off that as well. And then starting weight. This is always an interesting conversation with patients when they tell me kind of the goals they're setting for themselves at the first visit. And I usually talk to patients like I don't have a strong goal initially. My goal is to kind of make sure that patients feel like they have a good relationship with food, and then otherwise address other aspects of health that might be a concern here. Um, but I think that also plays a role as well. When we look at some of the trial data, I'll kind of quote this a little bit on the top of my head. For one of the new oral agents that came out, they actually sub differentiated each BMI group, and they saw that patients with the Foundeo actually lost more weight in a lower BMI category than patients in a higher starting BMI category who started the Foundeo, which is a little bit atypical of what we expect to see. I think in general, we tend to see or we expect to see patients with a larger starting BMI to see a larger weight loss, but that's not always the case. And then it's also kind of understanding where in the patient's journey you're catching them kind of in, recognizing that patients have different set points. And we'll talk about this, I think, with the next myth, but recognizing that patients who've been treated with different medications before are going to respond differently than patients who are new to treatment, or patients who've engaged in GLPs before or other modalities of weight loss treatments. We'll also see differentiating factors here. We also know patients who've gained weight and then lost weight kind of had like this weight cycling struggle more too. So this is kind of where it's really important for us to collect a really good history to understand like when we do talk about patients about options, how might this present differently for you versus your aunt, your sister, your friend? I think that kind of gets in the nitty gritty. What else have you seen clinically, Corey?
Yeah, no, all of that is very, very relevant to, things that I talk about with my patients and, those experiences they have as well. So one of the most common questions that I get in a new patient visit, usually as we're wrapping up is, what do you expect as far as, what should I expect over the next several months as far as weight loss? What should I expect with the pace? And, what should I expect? And, I share some sort of the summary of everything you just said, and that there are truly so many factors at play, depending on your age, your hormonal status, sex, genetics, all of these things, combined really impact how quickly we can see the weight start to move and at what pace that will continue to move. And dosing alone is such a huge factor. Just, like you said, some people have such a pronounced response very early on, and some it takes titrating for 3 to 4 months before we really start to see that solid movement. So there's just truly so much at play there that, you can't compare apples to apples. And I think social media really works against us in this way, just because there are as many Ozempic and Zepbound and Wegovy Facebook groups as you could possibly want available. And so it's very hard to not compare to someone else's experience and, not just with how quickly their weight was moving or, how effective the drug was for them, but also side effects. I have patients come to me all the time and they say, well, my friend's on this and she lost 50 pounds and never had a single side effect. And it's like, well, everyone's response is so different. So that definitely is an ongoing conversation. And I think the longer that, GLP-1s are used as treatment methods, the more factors we discover, because everyone truly is so different. And so that's definitely an ongoing conversation.
Yeah, I think to kind of add to that too, whenever I talk to patients, like I have a few patients who maybe haven't responded as we might have expected based off clinical trial data. And that's when I talk to patients too about, we're seeing a rapid expansion of treatment options now in the obesity world, which I think is so exciting to offer patients. And I think that's proof that it's ever more important. We know that GLP-1s might not be the only treatment option for a patient, hopefully in the future. And just because something doesn't work now doesn't mean something might not be a better option in the future for a patient too. It's always interesting to kind of think about mechanisms here. And so I know I do some like combination therapy, like thinking about GLPs with other medications. Sometimes that works a little better, or sometimes other, or like what I would consider like first generation treatments for obesity might be more beneficial for the right patient. So that's always something I think about too. And then going back to kind of what you said, Corey, about setting expectations, I love to talk about clinical trial data with patients because the minute I talk to patients about like expecting 15 to 20% of weight loss over a year to year and a half, I think it kind of helps paint the picture that this is not meant to be a quick thing. I know patients always come to me and say, like, the two questions I get asked is, how much weight am I going to lose and how quick am I going to do it? And so I always tell patients, like, this is a marathon. Most of my patients have been struggling with weight for their entire life. And so I always tell patients, like, goal is weight loss, but sustainable weight loss. I don't want to see weight loss that comes back again. I want to avoid the weight cycling. I want to avoid that roller coaster that happens. We know it's much harder to lose weight again. And so I really focus on sustainability and focusing on how do we make sure that this weight is maintained off. And so I think that highlighting that as the objective, I think can be really helpful too.
I couldn't agree more. And one thing along with that is that, I feel like one thing that sets Known Well apart is just that comprehensive method I think that all of our clinicians have in place for their patients. Whereas I think there are far too many weight management practices that are over medicating patients on GLP-1s unnecessarily, and they're having a therapeutic response at a specific dose, and then they're continued to be increased in dosage, without really needing that. And I think that ends up having patients in a compromised position where they even more feel like they have no appetite, they can't eat, they're under eating, their weight loss is unhealthily paced, very much so not sustainable. Really sets them up for more of that roller coaster of, like you said, the weight cycling over the next several years of their life. And I think that's something that's really special about Known Well is that we take a very different approach. And even if this takes a little bit longer, it's going to be worth it because you're set up for success and overall better health in the long run because you're not going to have to be going through this process for the next 10, 20, 30 years of your life. So,
Yeah, absolutely.
all right.
Yeah, and kind of going to thinking about like why this is important, kind of thinking about the care. I think Corey talked about a lot of these points, but recognizing that if we think about sustainable weight loss, we want to make sure the behavioral aspects are also sustainable, not just the medication aspects. But when we talk to patients about quality of weight loss, it really comes down to the basics around trying to prioritize less processed foods, proteins, fibers, fresh foods, thinking about movement, thinking about prioritizing sleep, managing stress. And these are things that, we're all human. They're not going to be perfect, and they'll fluctuate throughout life. And so our goal is to kind of find ways that we can find sustainable behavioral changes. And once again, these aren't things that happen overnight for most patients, but take a lot of time and investment. And so I think having a multidisciplinary team can be really helpful in recognizing we all have a different perspective to offer here. We all have a different level of clinical support. And so it's so interesting. I always have patients who see the dietitian and they come back and they're like, this tidbit that I worked on with our dietitian is such a small, like fine-tuning thing, but it's made such a big difference in my life. And I'm like, great. Like, I don't know why I didn't think about it. I don't know why you didn't think about it, but our dietitians thought about it. And I'm glad, like, I think just having a different lens can be helpful. Our goal is always to tell patients, like, when I focus on lifestyle changes, I don't want this to feel unsustainable. I never tell patients you have to cook every meal every day, but it's really about working with your schedule. If you're telling me you can't sit down for breakfast, that's fine. Let's find a quick, easy grab and go option for breakfast, but let's plan around it. So I think really thinking about the care team is really helpful in terms of sustainability. I take care of a lot of patients from a variety of backgrounds, and I think this is like a common theme I hear, especially with patients who've engaged with maybe like surgical options who've come back. It's kind of telling like it's this worked before, but it was not sustainable, or I've done this before, but it just doesn't feel sustainable. And so kind of finding a plan that feels that you could do this forever is really the important piece here. And then when life changes, when life throws a curveball, how do we adapt to that? How do we figure out a new routine at some point? So I really think that the care team, the comprehensive care team is super important in long-term success here.
I agree completely. And I think that we have such a significant number of patients that come to us who are highly educated, highly successful people that have a very solid understanding of the right things. You know, people come to us all the time. They say, I know what to do or I know what's right, but for some reason, I just can't seem to find the combination of what's going to work. And sometimes you're right that just a different set of eyes, sometimes I'll, you know, offered to refer someone to a registered dietitian and they say, well, I've seen one in the past. I kind of know what to do. And, my counter to that is it could be one thing that they share with you that's a different perspective than you've, ever been exposed to in the past. And that could make all the difference. So I also think that, chronically in our culture, the less is more phenomenon is such a epidemic. And I think that sometimes that's not the case. It's not always that we need patients to be, in such a large caloric deficit, and that's the primary thing we're focused on to losing weight. There's so much more at play there. And so, obviously the nutrition counseling, but also just lifestyle and the understanding. And that goes back to your history. What kind of history are we gathering in these new patient visits? And, how well are we truly getting to know this person and the lifestyle behind what's driving all of this? And I think that's one thing that definitely sets us apart.
Yeah, I know. I think that's an interesting point you bring up. I think I bring up the dietitian. It's kind of 50-50 in terms of how often patients want to engage. And the way I frame it is, A, what's the worst that can happen? Whatever's been on the trial before hasn't necessarily worked. So like, why not try something new? And then I usually talk to patients about, I think it's also affirming to hear that things are going well. Like if things are going well, great. Like it's nice to know that, we've kind of optimized from a lifestyle perspective. I think a lot of patients blame themselves for weight when we know this is a chronic disease state. And so I think there's this hyperfixation of I need to work on my nutrition, I need to work on my exercise. And I think it's okay to say I'm doing all the right things or I'm doing most of the right things, right? Things don't need to be perfect once again. But I think it's good to acknowledge like, yeah, I'm on the right track. I'm not going to be perfect. I'm a human. How else can we target this disease state? What else can we do to work on this as a team?
Yeah, I love that. And I love that you use the word human because that's a sentence I say probably 20 to 30 times a day is we want to keep this human. We want this to be sustainable. You're not a robot. That's something that we're working really hard to maintain. So all
Yeah.
right, moving right along to our next myth. So, myth, you have to take a GLP-1 forever. This is such a common topic of conversation amongst patients and, weight management practices and obesity medicine clinicians is this true? Is this not? And the fact is that, again, treatment is very individualized. I know you guys have heard me say that 10 times now, but that is the truth. So, Sri, tell me a little bit more about your thoughts on this topic.
Yeah, absolutely. So interesting because I think when we think about GLPs, I think we need more long-term data. So when we look at some of the trial data so far on the medications we have on the market, in the trials, these clinical trials have shown that when patients stop one of these treatment options, that they do see some weight regain happen again. So on average, especially in the treatment trial, specifically for semaglutide, otherwise known as like Wegovy or Ozempic, around patients regained around 2/3 of weight over a year. In the real world, I think it's somewhat similar. I know kind of we talk about here the second kind of bullet kind of talks about a little bit about looking at charts and seeing how patients do once they stop GLPs. Some patients are able to see continued weight loss. Some patients are able to see increase in weight or weight regain fully or partial weight regain. Um, the second kind of point here I'll take in the sense of chart data doesn't tell the full story. So kind of I'm going to focus a little bit more clinical what I tend to see with patients. I find that a lot of patients can tell the changes in hunger. So when I talk about GLPs in general with patients, I'm not really focused on number on a scale, weight, but I'm talking about how do you feel about relationship with food? How do you feel about hunger? How do you feel about satiety, cravings? I think that's going to be generally a better marker of if this is working than number on a scale, at least initially. I think we can kind of understand if those things will happen if we're seeing those changes in relationship with food. And so oftentimes, unfortunately, when patients stop these medication, whether it's personal preference and there's a wide variety of reasons why patients stop these medications. But more often than not, I think I see patients come back and tell me I'm feeling hungry or I'm seeing a change in my relationship with food. We always talk about how to augment that. Can we do the things naturally with lifestyle changes as well? Every once in a while, I see patients who don't actually have that. I saw a patient a few weeks ago who had stopped for a full year and maintained the exact same weight, and I don't quite know how to explain it. I think this patient, and this kind of is where going back to that history is really important. I think when I think about patients who I think will struggle more with stopping and starting are patients who've done more weight cycling, or who weight has been a concern more chronically, long term. I find that when we're catching patients earlier on in the disease state, we're more likely to kind of see success long term without treatment. But I think this is where it's very individualized. So there's some patients we talk about, maybe we can see what it looks like without the GLP and maybe restart, or we see patients who don't need the GLP and stop. More commonly, what I think I see patients do clinically are patients who take the medication less frequently or take a low dose longer, long chronically. So I think maintenance looks different for a lot of patients. But I think this is a very individual discussion. I always tell patients, my goal is to do what you want to do, is to kind of focus on what your goals are. I always present like the research. I tell patients this is what I see in the clinical trials. This is what I see with my other patients. This is what I would present to you. And I want the patient to be comfortable with that decision, whatever that is. And nothing's permanent. Once again, if a patient stops and wants to restart, we can. If a patient wants to continue and stop later, we can. There's nothing permanent. There are plenty of medical reasons sometimes that we talk about this. So a hot topic that comes to mind is always planning for pregnancy. I find that that's when we talk about stopping these medications and planning for that pregnancy. So that's always a challenging conversation to have. Um, but I think this is where we need more long-term studies, right? When we think about these drugs, we've had them since 2004 for patients with diabetes. We've had them since 2014 for patients for weight reduction, but we don't have as many long-term studies to understand what does life look like long term, how do hunger signals change over time, and what dictates some of those changes. So, um, what are your thoughts, Corey?
Yeah, absolutely. This is definitely probably the most time that we spend
Mhm.
talking about one of the topics in patient visits, I would say, is, am I going to have to be on this forever? I think there's definitely a sense of empowerment that patients feel when they ask that question and they are met with, we're here to do what your goal is. Because I have found that a lot of patients that come to knownwell have been told by another practitioner at some point in their weight management journey that, if you start this, you're going to have to be on it the rest of your life. And for some people, they're okay with that. For some people, that feels very daunting. And so I think that approaching that, and just, taking that individual's history and making it very clear that, we're their advocate and we want, this to work for them and their goals, I think starts off on the right foot. I think there's also just so much variation with this depending on the patient's past medical history. People that are coming in with type 2 diabetes, hypothyroidism, things that already make it innately harder to maintain a specific weight or to lose weight in general. Of course, those people are going to be at increased risk of, of having weight gain when stopping a GLP-1 and things of that nature. One of the things that I heard Dr. Fitch say, our chief medical officer, in a recent podcast was that, metabolic disease is something that's treated on an ongoing basis. She said if you have pneumonia and you get treated, you cure that pneumonia and then you only have to take a medicine if you get it again. But metabolic disease doesn't just go away. So when people come to us with these pre-existing conditions, we're treating them for that. And then if they come off treatment, we can't really expect that that's going to go beautifully. But for people without those, predisposing comorbidities and things like that. I do think that a big emphasis on lifestyle changes and, how are you eating? What's your relationship with food? Like you've said several times, what's your activity level look like? And just things of that nature, trying really hard to set them up for success while they have the GLP-1 on board. We know that during that period of time, your appetite's going to be down. This is the time to focus on your relationship with food, kind of develop a routine where you are eating, hopefully more frequent, smaller portions of food. We're working to, improve your metabolic function as much as we possibly can via conservative methods, so that, if and when we do reach the point that they have, been maintaining their goal weight, they choose to come off of the GLP-1 where we've hopefully helped them prepare, in the best way possible to be able to maintain their weight. But it's just something that's so personal. And I think, continuing to give patients that choice and feel empowered that this is about ultimately their goal, I think is one of the biggest things.
Mhm. Yeah, and I think I want to emphasize a point you made there, Corey, is kind of taking a step back and still recognizing that obesity is a chronic disease. I think we sometimes still think of this as like a lifestyle issue or a moral failure, but this is a chronic disease influenced by so many different factors. And so it's kind of the same concept of if I saw someone with high blood pressure, I wouldn't just say cut out your salt and blood pressure would be better. I would still say, like, let's work on these lifestyle modifications. Let's increase your activity. Let's reduce smoking or nicotine use. Let's decrease salt intake. um, let's think about a medication. Absolutely. And then there's sometimes when patients are able to modify those lifestyle changes and blood pressure reduces and we can stop the medication. And there's times where patients work on those lifestyle changes and blood pressure doesn't budge. We still know there's many other health benefits for doing those changes, but sometimes it doesn't change. And so, there's genetic factors that drive into there too. And so I find personally, I think sometimes even just acknowledging that obesity is a chronic disease is a helpful place to start with patients and kind of recognizing, and when we think about this as a long-term treatment, it's because we're recognizing obesity as a long-term condition. And so recognizing that that's not magically going to go away either. We want to be able to support that from this like interdisciplinary lifestyle approach, but sometimes further treatment is really helpful. Um, Corey, do you mind going to the next slide? I think this will actually transition a little, well, awesome. Yeah. So kind of going back to this idea of like weight cycling and thinking about patients who gain weight and see weight shifts throughout the life, we know that so many factors kind of play into this. We know that changes in hormones, so puberty, pregnancy, menopause can trigger changes in weight reduction. We know that stressors can trigger changes in weight reduction. And every time patients lose weight, our bodies don't love to see that weight reductions. Our body gets really nervous about when that weight reduction happens. And so naturally, our body tries to make us feel hungrier, have more cravings. So what works now from a treatment perspective might not work in the future. There's like this consistent metabolic adaptation that's happening too. And so that's kind of why also I think about this as a long-term treatment. But I also tell patients this might not be the long-term treatment. Whatever we decide today or whatever is working today might not be the same tool that you find as helpful in the future, or something might change where we don't, to your point, we might not need this anymore. But we think about this in terms like our body is constantly adapting to the shifts. We're also kind of encouraging on it too. So it is this constant like tug of war that happens with teen patients, between like us and our metabolism, that our body's constantly fighting. And it's not a fun fight, but thankfully we have more tools to kind of think about it. So.
Absolutely. That was great. All right. Our next myth is that muscle loss isn't something to worry about. The fact is, roughly 20 to 40% of total weight loss on GLP-1s can come from lean mass. We're going to talk a little bit about the difference between muscle mass and lean mass.
Yeah, absolutely. So we have both lean mass and muscle mass. Lean mass is anything in the body that's not really, includes muscle mass, but it can also include bone mass. It can include some muscle mass around the organs and fluid. And so when patients are losing weight, whether it's with GLPs or without GLPs, with any other type of intervention, there can be some loss of both muscle mass and lean muscle mass. That's not generally, that's something we want to see. We want to see that organ improvement. We want to see less fatty liver disease. We want to see less heart disease. So these are benefits that we want to see as well. But we don't want to see a lot of like muscle mass. When I think about like muscle mass, we want to make sure we're maintaining strength and independence. I always talk to patients. What is the point of doing this if we're not thinking about your quality of life? My goals for patients are to to be independent, to do whatever you want to be able to do physically, mentally, emotionally. But I think part of that comes from muscle mass. It's recognizing that we have to be strong. Long term, when we see shifts in muscle mass, when we see a decrease in muscle mass, that doesn't help us with long-term weight maintenance either. Muscle mass plays a role in this metabolism. It's where we burn energy when we're not doing as much, when we're not as active. And so if we lose muscle mass, it's harder to maintain the weight loss that's happening. So it kind of counteracts that metabolic adaptation. I think patients always, like, a common question I hear is, how can I boost my metabolism? And so in kind of thinking in that mindset here, building muscle mass can help support metabolism. So I think it's really important to be a top priority for patients going through a weight reduction journey. Even more important to think about patients engaging with GLPs, and thinking about long-term sustainability there as well. What do you see typically, Corey?
Yeah, absolutely. It's definitely a big topic of conversation. And I think a lot of patients may come into it with a different mindset and they're worried about losing muscle because they're worried about loose skin or they're worried about cosmetic things. And then as we start to talk more about that subject, we really get into the nitty-gritty of why this is actually a lot more important than just that. Of course, we all care about the cosmetics. We want that to not be an issue down the road for patients or something that they feel uncomfortable with. But maintaining muscle mass is huge. You mentioned quality of life. We think about our patients that are, 60s, 70s, 80s. We treat patients of all ages and, critical that we're maintaining muscle mass, decreased risk of osteoporosis, and just, working to maintain functionality. We want people to live life to the fullest. We want you to be as active as possible. And so keeping that muscle mass, having the ability to build lean muscle mass if and when people want to do that through resistance training and things like that is imperative. And so I think, from the jump, when I see a new patient and we're talking about starting GLP-1 therapy, we're talking very heavily about protein intake and talking about, what does that look like for you currently? What's something that feels doable to start? And then we'll kind of work our way up depending on where they are. And I think that makes people a lot more comfortable with the idea of it, especially if they're not really used to tracking something like that. But that's super important up front. And I think too, that's where it comes into play talking about the more frequent, smaller portions of food, because when people are thinking about, how in the world am I going to hit 90 grams of protein a day or, whatever their personal goal might be, thinking about sitting down to eat three largish meals a day where you're, having 6 ounces of chicken, it doesn't feel super doable to a lot of people on a GLP-1. So working with them not only from an activity standpoint, but from a dietary standpoint on how can we achieve this in a way that's healthy and doesn't feel overbearing every day, I think is super important up front. So
Mhm. Yeah, I think that's a great point too. I know a lot of my patients ask about like tracking and calorie counting, and I oftentimes try to shift the conversation to tracking macronutrients if we're tracking anything, kind of thinking about how do we think about fueling our body versus focusing on this like elimination kind of mindset. How do we fuel our body? How do we make sure we're incorporating enough proteins and fibers? How is this going to help the overall mission of quality of weight reduction? I think can be like a really helpful mindset thing as well. Once again, another big plug for dietitian support. I think they're really great at helping with this. I think a lot of patients have done some sort of calorie counting before seeing us, and so it can feel really redundant. It can feel very annoying. I have plenty of patients who can tell me, like, this is this many calories off the top of their head from years of doing it. But when I ask them about the macros, it's interesting because it's not something that's really been talked about or focused on. I know our dietitians really try to make it accessible for patients. Um, I know we utilize some fun tools in our clinic. We have a app that you can take a picture of your meal and it can pretty well like guesstimate how much protein and fiber is in it. And the best part about it is when you meet with a dietitian, they can see the picture on their end. So they can do a little bit more estimating on their end to fine tune. Um, I know in my visits, I always ask patients, like, what did you have to eat? And it always is drawing a blank. And so sometimes having this tracker can be helpful too, more just for the accountability. I love the tracker that we have too, because it has patients aim for a protein goal. It's not a calorie goal, but it's like, here's your daily protein goal, here's your daily fiber goal. How are we going to get there? And I think it kind of helps shift that mindset.
yeah, absolutely. And I think that's super important because I feel like diet culture, especially in our country, is so fixed around calorie counting. And I think a lot of people come to us with this idea in their head that, oh, I'm going to be eating 1,100, 1,200 calories a day. That's how I'm going to get to my goal weight. And I think people are honestly quite relieved when we start to have a more in-depth conversation about that. And they find that I'm not wanting them to be in that large of a deficit at all, because we want this to be something that's truly sustainable. And of course, from a scientific standpoint, there is proof to being in a caloric deficit and, losing weight, but there's also data that supports being in too large of a caloric deficit really messing things up in a lot of ways. So I think people find a lot of relief in knowing that, this is not an overly restrictive plan. We're looking to set you up for success as far as, fueling your body appropriately for the long term. And, with that comes maintaining muscle mass. With that comes the functionality aspect. So I think it all goes hand in hand for sure.
I think that's a great call out, Corey. I think going back to like speed of change and rate of change, I think a lot of patients focus on the bigger calorie deficit, the better. But going back to sustainability, that's not actually what we want. And when we think about quality of weight loss and losing muscle mass, we also expect to see bigger changes in muscle mass with more rapid weight loss. So it's not really in line with like overall goals or long-term success here. So I think that's a really important call out in recognizing that the goal is gradual changes. both from a sustainability aspect, but also really a quality aspect. I think they kind of go hand in hand. And that's when I think about a lot of discussion we have with patients, I think are very like overlapping here in the sense of they fit patient goals, but also clinician goals. I think it's kind of a matching system of how do we keep patients doing the best they can as long as they can.
Absolutely.
Yeah, absolutely.
Right.
Yeah. I think this kind of highlighted a lot of the points we kind of talked about, recognizing that we want to make sure patients are focusing on those macronutrient goals, thinking about how to get enough protein in, thinking about resistance training programs. Resistance training and strength training is so interesting to talk about because I think this is something that doesn't really come natural for most patients. I think when we think about nutrition, I think that's something that we all eat, we all have to engage in it. We all have some kind of general basis there. And I think when we think about cardio activity, I think for people that's a little bit more tangible, whether it's, walking, biking, but people are generally engaging in some activity. But resistance training is hard. It's something that you have to be really thoughtful about. You have to have a plan for. And most of us don't get a lot of education or knowledge around this. It's not something that's taught in schools generally. There's not like a set program out there. There's a lot of programs on the internet, a lot of information on social media, but it's hard to come up with a targeted program. I'll say personally, kind of when I started this field, I was like, okay, I need to get my act together. I have to start weightlifting if I'm going to talk to patients about this. So I need to get my act together. And the first few months, I was doing a program that I thought was enough, I thought was sufficient here. And I was kind of just doing weights in like the basement of my apartment, kind of coming up with my own program. And after like 6 months, I thought I was doing a fine job. I thought it was okay. I decided to meet with a personal trainer. And I was like, I could have been making so much more moves here. I could have been progressing much more. And part of the reason is I didn't know what to do. I didn't know how much to do. I didn't know how to challenge myself appropriately. And so personally for me, I thought it was very helpful to meet with a trainer to get that structure and get that knowledge. And so I always encourage patients when they're first starting in this journey. I know it can be an expensive investment, but I talk about small group training or some sort of personal training can be really helpful, or looking in your community classes. But I think getting that support initially can be helpful in getting over that initial hurdle of how do I do this? What am I doing? I always tell patients, if you're going to spend 20, 30 minutes to do this, it should be a good investment of your time. It should count for something. And so I don't want you to do something for the sake of doing something, but I think having that structure to implement is really helpful. But I'll say it's definitely a work in progress, I think, for a lot of patients. It's really hard to do and really hard to be consistent with. I don't know if you have any tips you share with patients, Corey.
No, it's really funny that you mention all that because I resonate completely. I started strength training about 4 to 5 months ago, seriously. I had done it off and on before, but had never really had a dedicated regimen. And it's been pretty mind altering, to be honest. That's learning so much as I go. And you're right. I feel like at first it's kind of very easy to be just floundering and not really, knowing exactly what you're targeting or how much to lift and when and how many days a week and all of these things. So, one of the things that I talk about with patients the most is limiting extremes. So, one thing that I find with a lot of folks that come into this, they've not really done much resistance training. Maybe they don't have a super strong exercise background in general. Some people come into this and think, oh, I'm starting a GLP-1. If I'm going to do this, I'm going to go all out. And so I'm going to go to the gym 6 days a week. I'm going to do this many days of cardio, this many days of weightlifting. And I think the motivation and the drive is great, and we want to capitalize on that. I also think that just like with everything else we've talked about, sustainability is critical. So I talk to people a lot about, keeping things balanced. So if you're going to start this, you need to start it 2 to 3 days a week. See how you feel. Let your body acclimate to that. And also in the process, as you're trying things out and figuring out what you really enjoy, develop your routine about around what you really enjoy. Because, if you are forcing an exercise regimen that you absolutely hate and you're dragging yourself to the gym 3 to 4 days a week to do something that you cannot stand, you're 10 times more likely to not do it. So, I tell people all the time, especially my, older female patients who, don't really want to get out or go to the gym. They'd rather just do something at home. If you want to do, dumbbell Zumba in your living room and that's what you really enjoy, then go for it, but finding something that, really works for you makes you 10 times more likely to stick with it. So I think really just limiting extremes, promoting balance and promoting something that is sustainable because you enjoy it, I think are some of the most helpful things starting out.
Do you mind going to the next slide, Corey? I
Yeah.
think that'll transition well. I think to really echo what you just said here is I oftentimes tell patients like this is a good time to experiment with either things you really like or the other goal is we have to find something you don't hate. And I laugh when I say that because I think for some patients, just like movement is not their jam. It's just like it's not something they've ever done. It's not something they want to do, and it feels like constant homework. And I have some patients, and I think especially some of my adolescent patients really struggle with this. And so I always talk to patients like, what feels sustainable? What helps with the accountability? How do we make this less miserable? Whether it's do we do this with a friend? Do we start with once a week, to your point, Corey? Do we have you listen to a playlist you want to listen to? Do we do it at a certain time of day? But when I think about exercise goals of patients, I really like to get very specific with them in thinking about like how do we make this less miserable? Like if you told me your goal is to do this in the morning, but you hate waking up early, it's not going to happen. Like that doesn't feel like a sustainable goal. But I talk to patients like, do we think about a goal of we're doing this once a week on Wednesdays because you don't have a class after work and you get to come home straight after, so you'll be done by 3. And so we're going to use 3 to 3:30 before your kids are home. And we're going to do it at your home so you don't have to travel and we're going to follow this person on YouTube because you have YouTube and this is easy to follow. Like it's really thinking about getting into that nitty-gritty kind of pathway, especially initially, because it feels like a barrier to overcome, I think, for a lot of people. Um, and I talk to patients about pairing this. Like I have one patient who likes to go on their Peloton and just watches like a movie the entire time, especially like in the summer. She's like, I'm home by myself. My parents are working. I know I need to do this. And she'll just watch a whole movie on, on her Peloton. And she's like, I'm not going very fast. I'm like, that's okay. You're sticking to something that works for you. And if you feel like you want to change your activity goal, great. If you're telling me like, nope, this is better than nothing, I'll take it, right? It's kind of figuring out like what does that look like for patients. I asked to switch to the slide. So Dr. Fitch is our chief medical officer. That's a picture of her and I. We have the same personal trainer, and our personal trainer always says a good weightlifting routine is boring because it's the same thing over and over. It's not that exciting. It's a boring program. You're generally doing very similar activities, but the goal is you're lifting heavier weights through that process. And so she always jokes with us that this should feel boring. And so let's make it more fun. Let's do this together. Let's listen to a good playlist while we're doing it. I'm now friends with her, so now it's a social hour. But how do we make this more entertaining so you're going to stick with the program, and make it feel consistent? So I think just highlighting those points as well.
Yeah, absolutely.
Mhm.
All right. So moving along here, we've talked about a lot of myths versus facts. Now we're going to talk a little bit more about why known well. And we've touched on this a little bit throughout, as we've been talking about our approach and how we, meet patients where they are. But I think when it comes to what sets known well apart, we really have a bias-free weight management care approach for every single patient. So like I've mentioned in several of the things that we've discussed, it's very individualized to you. We lead with empathy. We're not looking to be like every other, weight management practice you've been to in the past where it felt taboo to talk about, all the things that you wanted to talk about with your weight journey. And, this is here to be a very destigmatizing process. So we want to provide the most comfortable atmosphere possible for people to feel safe and to be met where they are and develop your care plan around you. So, and just like we've talked about with the interdisciplinary approach, we have nutritional counseling. Our registered dietitians are phenomenal. Coaching built into your care plan. So, this is something that you may not experience at a lot of other weight management practices where you're just meeting one on one with a clinician and there's not a whole lot of other resources. Our care team was built around trying to provide that whole package so that patients feel like they have all the resources at their disposal in this process. And of course, access to medication. We have wonderful clinicians that are very up to date on, all of the things weight management, all of the medications that are, available and different options based on your past medical history and what may be going on in your life. So, world-class experts in weight management, I can confidently say, along with Dr. Bodepudi, we have some of the most wonderful clinicians here at knownwell that I've been incredibly lucky to train under, to learn from, and to work alongside every day. It's truly been incredibly impactful in my own career and, seeing what I want to continue to unfold for the next several years of my career and, the type of care I want to be able to provide for patients. So, such a wonderful team, and just honestly the most welcoming um, and just amazing atmosphere I've ever experienced working for a company. So I think that really translates into our patient care and, how we really strive to make patients feel in every interaction.
Yeah, I think to like echo off that, Corey, I think it's interesting always like if I have a patient that I'm like, this isn't working, I need a second set of eyes. It's always like nice to talk to someone within known well about like what they would recommend or what they would do. We've always had clinicians welcome to kind of like I'll see your patient one off and see if I have any recommendations and I'll get to meet them and know them. And so it's always nice to kind of know like there's as we see more emergence in this field, there's not a clear pathway. There's not a clear like algorithm quite yet of like if this then do this. There's not kind of that set of directions created yet for when we think about treating patients with obesity. And so I think it's really important to think about like how do we customize care? How do we really think about care in this individual? What is working, what's not working, and how do we hold on some of those opportunities? I think one of the first points you made was really interesting, like care that leads with empathy. It's just and thinking about patient goals. I think that's so interesting. Like one of the first things I do in a visit with a new patient is ask about goals. And if, oftentimes a lot of patients have like specific weight goals or a number on a scale. And I often ask like, why that number? What does that mean? And they're like, oh, my doctor told me I should get there. And I'm like, okay, like tell me more. Like what is going on here? How are we kind of getting to this point? But it's interesting once patients start this journey. I have a lot of patients who tell me like, I know I shared that goal with you, but I don't really feel strongly about it anymore. Like I see other what I call like non-scale victories. I think that's one of our favorite words to use in our clinic is what we call non-scale victories. What other wins are you noticing in your health, in your personal life, that are kind of happening as a result of changing your relationship with food here? So I think it's always fun to kind of really focus on those, and it's interesting to see how goals change. It's something I talk to patients about at least annually, if not more frequent than that. And it's like, okay, like you're in this process now. You were, 6 months ago, this is all very new to you. Now you're in it. What are you noticing? What do you think is more important at this point? How do we kind of structure on there too? I think there's a few questions in the Q&A we'll get to about kind of thinking about like plateaus and weight cycling and stuff like that. And I think I always try to think about like what is the long-term plan so far? Like what's happened so far that we can still celebrate, even if it's not quite where a patient wants to be. So I think there generally is plenty to celebrate still. So
I agree. One of my favorite things is in a new patient visit when you ask those questions and you're really trying to figure out, what is the motivation behind this. My favorite thing is when someone doesn't lead with a number, but instead they say, my goal is to hike XYZ with my grandchildren, or my goal is to do this thing, and it's always really inspiring. And then once you reach the point in their journey that they did that, it's such a full circle moment. It's super cool to see both from our side and of course from the patient side, but that's definitely one of the most rewarding things.
yeah, definitely love hearing those goals. And it's so fun because we don't get to dictate that, right? It's so fun. The patient gets to create that goal and they get to tell us whether they met it or not. It's like we're just here. We just get to enjoy the ride. So it's really fun to see when patients come up with those goals and meet them. Agreed. Mhm. Yeah. I want to take a minute to talk about known well outcomes. And I think this kind of ties back to our last myth here. One of my favorite things to talk about and brag about when we think about known well is thinking about how well our patients do. I think kind of tying back to some of the myths and facts we reviewed today, when we think about patients who work with clinicians at known well, we tend to see less muscle mass loss compared to patients who were in the clinical trials with these medications, with the GLP specifically. So we know that there's something between our discussion with patients, coaching, working with our health coach, working with our dietitians that's really resonating with patients, where they're able to make more sustainable lifestyle changes. I think that's a term I often hear from our patients who work with our dietitian of these changes feel sustainable. We see that 74% of our patients lose at least 10% of body weight. We see that patients are able to sustain that weight loss result around 97% of patients. So we get to celebrate a lot of wins, I think is my takeaway. We see patients do really well in our program. And I think part of that is we get to meet patients regularly. I always tell patients especially my long-term patients who have been doing this for a while. I'm seeing you every 3 or 4 months because you're rock and rolling. But if something's not going well, you know where to find me. I'll fit you in. We'll meet sooner. We don't have to wait that long. But if things are going well, great. But if they're not, you know where to find me. We can always reevaluate our plan. We can always readjust. This is a chronic disease, and so our game plan might need to change.
Yeah, I love that. I think the accessibility of our patient care is something that really draws a lot of people to us and makes people want to continue working with Known Well because I think, in traditional, medicine, whether it's primary care or specialty medicine, sometimes you're waiting, 4, 5, 6 months for even an initial consultation. So I think patients feeling like, we do have that flexibility. We're able to get you in if something changes, because life happens and there are unforeseen things that are going to happen all the time. And I think that provides a lot of comfort, especially for patients coming into this who've never been on a GLP-1. This is their first time really kind of like traversing their weight management journey. I think that just provides a lot of security and is something that, really sets Known Well apart and we strive to maintain.
I think echoing off that too, I think I have a few patients who just have done so well with us and they are moving or something's changing. I think knownwell has now expanded to a 50-state virtual care model. So if a patient moves somewhere else, they might not be able to see myself, but they can see another clinician. And I think that helps alleviate a lot of fears. I think patients who are like, I've been doing so well, I'm worried about what support looks like without you. And I'm like, you don't have to do this. Like we have other clinicians, might not be me, but you'll still be in great hands. I know you're in great hands. You can always reach out if you have a question, but it's nice to know that patients can still get this care anywhere. This has been especially so fun for my patients who are like kids who are now going to college, and I'm sending everyone to school now. And the kids who are leaving state are moving out of state who I'm going to have to say bye to. It's so nice to know that they're in good hands. College is a tricky time, a lot of transition, and so it always makes me nervous to send these kiddos off. So always very excited that they have an option to follow us.
Yeah, absolutely. That continuity really is everything.
Yeah.
All right. I think we are at the point where we're going to do some Q&A here. So let me see if I can find the chat. I'm going to stop share so that I can see the chat. Okay.
I'm going to take this question here at the bottom here. This person is asking, I'm on the lowest dose, but continue to lose weight. I don't necessarily want to keep losing weight. What are recommendations? And then they kind of talk about some other medical issues, which I'll leave out just for the sake of keeping this a little bit vague. I think this is definitely where I would want to make sure you contact your clinician and have a discussion around this. Um, this can happen. I think when I always like see patients continue to lose weight and maybe they're past that weight goal, I kind of take a step back and say, why? Is there something that is kind of acutely changed in life? I think for a lot of patients, like mental health changes can be a factor, sleep changes, different patterns. So I always take a step and say, like, hey, what's going on from a lifestyle perspective? Has anything changed? Sometimes patients are hypersensitive to these medications. And so I always talk to patients like, is this still the right treatment option? Do we need to decrease dose? Do we need to space out dosing? Or is this not the right option for you? I have some patients who going back, I think the average weight loss with these medications is 15 to 20%. I have a patient who's lost 48% with the lowest dose, and that's a significant amount of weight, right? And might not need to necessarily lose more. And so we talk about like, is this the best option? Is this not? And just to clarify, that's very gradual over time, but has seen like big change, like something that I wouldn't necessarily expect to see for a typical patient. So this is where I think it's really important to really get into the nitty gritty and kind of figure out like what's going on here, what's going to help with your sustainability pattern.
Yeah, that's good. Just for the sake of time, I'm going to jump to another one really quick here. I got a question. If I'm on the lowest dose but continue to lose weight and don't necessarily want to, what are your recommendations? I also have Invisalign that adds to weight loss. Never thought I would say I feel too skinny, but I do. So I think this is a scenario where you need to have a very in-depth discussion with your clinician. Depending on your past medical history, you and your clinician can discuss, is it appropriate for you to come off of the medicine or maybe revamp your maintenance plan a bit? If you're still dosing every single week, every 7 days, maybe considering stretching that out to every 10 or 14 and seeing if your weight movement slows and you're able to kind of maintain easier at that threshold. But that's something that needs to be very personalized to you. So I definitely have an in-depth discussion about that. But if your BMI is getting to a point where we're borderline too low, we start to worry about, hormonal changes, hair loss, things of that nature. So that's something we really want to stay on top of. So I would recommend not letting that go too long and kind of figuring out what changes need to be made to your care plan.
Another question I want to take here, let me go back to it. Questions kind of focusing on what advice do you have for people who have been on medications for a few years successfully and they don't work as well at this point? Specifically, the side effects are pretty much gone, but that means eating more starts happening and a little weight creeps back on. Very great question. This is something that we see all the time. So going back to this idea of weight as a chronic disease, obesity as a chronic disease, I find that what you're describing can oftentimes happen with patients. We recognize as patients lose weight, those hunger cues kind of come back. Our bodies don't love being in this calorie deficit and get worried about it. And so they try to make patients hungrier, have more cravings. And that's kind of where I sit with patients and fine tune here. Like what specifically is changing? Are you noticing relationship with food changing? Are you noticing changes in satiety, cravings, hunger? Is it harder to feel full? What does nutrition look like? Kind of getting really nitty gritty here. Um, Generally, for a lot of patients tell me like the fullness cues change or like that food noise kind of concept changes quicker than like the hunger itself. And so that's kind of where fine tuning is really important. But that's exactly why this is a chronic disease, and that's exactly why what's something that works now might not work in the future, and vice versa. But this is usually a case where definitely please talk to your clinician. But I usually kind of talk about the lifestyle modifications here. What's kind of working? Have there been any changes? Are there other stressors? Are there sleep factors that are changing? We know that those patterns can really influence hunger as well. And then I talk to patients, is it appropriate to add a medication to your treatment? We know in the future there will likely be more efficacious treatments in the option. So is the goal kind of weight maintenance right now until that can happen? So a lot of factors to think about, a lot of pieces to kind of think about here, but all really important factors to think about in making this next step.
Yeah, absolutely. I've seen a few questions here on hair loss, which is becoming a more common topic of conversation, I would say. Some people don't experience any hair loss on GLP-1. Some start to experience it more so as they titrate up in dosage. There's a large variance there, but as far as treatment of hair loss on GLP-1s, it is reversible. So if it's something that, you go down in dosage towards a maintenance plan or it's your goal to come off of a GLP-1, we do typically see that reverse. So that's not a long-term concern. If someone is experiencing that to a significant enough degree, we do have treatment options. We can utilize topical agents such as like topical minoxidil, things like that, which is an agent that helps support hair regrowth. In some scenarios, if patients have, severe enough side effects as far as the hair loss goes, we can consider like an oral minoxidil. So there are treatment options. It's something that's very much on a case by case basis. We, of course, also want to support all of our patients from a nutritional standpoint and just avoiding generalized deficiencies. So everyone on a GLP-1 should be taking, a daily multivitamin, things of that nature. So we make sure that we're covered in that aspect. But yeah, that's going to be very individualized, but we do have options.
Mhm. And I'll take one last question here. This question is any feedback or guidance when it comes to facing a plateau or a stall after being on a GLP for a few months? So kind of similar to kind of how I answered previously and recognizing when I usually tell patients hitting stalls is generally a good thing. It generally means we're on the right track. I find that a lot of patients are kind of excited about increasing the dose pretty quickly. And I often tell patients like if this is working, you feel like hunger is well controlled, you're seeing weight reduction, we're doing great. And if the time to kind of think about changing dosing is if weight kind of stabilizes and you're noticing more hunger. So stalls aren't bad things per se. I think it's kind of a reflection going back again, like weight reduction will likely cause more hunger over time. And so there will be some sort of plateau. Um, for the most part, we don't see patients, and I say this for the most part, generalizing here, we don't see patients like disappear on these medications, right? Like most patients have a limit to what we see. This is why the average weight loss we saw in the clinical trials is like that 15 to 20% range that most patients hit earlier than the 72 weeks the trials go on for. So patients kind of hit that weight goal and kind of maintain. And that goes back to that biology, that metabolic adaptation that's happening here too. What to do when this happens? So once again, I think I'm sorry the advice is it's very similar, but going back to this idea is thinking about what is going on lifestyle wise, what's changing from a day-to-day perspective, what are sleep patterns looking like, what are stress levels looking like, what are those coping mechanisms looking like, what does that lifestyle look like that maybe needs a little fine-tuning. Is there room to go up on the GLP? Is that appropriate? Is it something where we think about adding a treatment? Um, for example, I had a patient who's been under a lot of stress lately and has kind of noticed things stabilize. And we talked about like stress management techniques. We actually talked about like, is this to the point where we need to think about a medication to treat anxiety, not necessarily weight reduction, but anxiety in general. So that's part of the conversation as well. And then having a discussion like, is that okay if this is temporary? How long do we kind of work on this for? What does that look like long term? And then being mindful of all the treatment options available. So we talked about lifestyle, we talked about medications. We didn't really talk about surgical options, but recognizing that there might be room for that depending on the patient as well. But engaging that full toolkit, I think, is always important. So, yeah.
Absolutely. Thank
Yeah.
you all so much for joining us today for this webinar. We would love, if you're not an existing patient, we would absolutely love the opportunity to take part in your care. So definitely reach out with any questions that you have. If you're interested in scheduling, you can go to the knownwell website and we'll be super excited to have you. So thank you all so much for joining today and have a great rest of your day.